Good evening, ladies and gentlemen. It's a pleasure to be here and be the recipient of such a kind welcome by Johannes and Thorsten for creating the opportunity for me to come again to see my friends, colleagues, and my long association with German cardiology. And I stand between you and Oktoberfest. So I will try to see that you get to the more important event in time. May I can have my first slide, please? Is it coming up on the screen? So the title that Thorsten gave me was one that surprisingly in my career I have not done very often. The interventional treatment of arrhythmias, and I've interpreted this in a broad way, and my personal journey there. My current home at Rutgers University, and I continue to work with our research foundation. This lecture is a dedication to my dear friend, dear colleague, and a collaborator for over 3 decades. Bernd Luderitz and I met 40 years ago, and I was intimately involved in working with him in so many different projects. We are family friends for decades, so that we have known each other. And we lost him 3 years ago. Bernd was a physician educator. He was a historian and a true scholar. Latin and Greek were his second languages. So again, today I remember Bernd. These are my disclosures. So, interventional electrophysiology, I'll show a couple of slides. This is in honor of Bernd. And, this is the first recorded instance of sudden cardiac death. There's a physician putting his ear to the chest of a patient who has died suddenly and trying to hear a heartbeat. So sudden cardiac death was the opening gambit in the story of interventional electrophysiology. Interventional electrophysiology is one of the most incredible stories in 21st century medicine. Look at the interventions we have: pacemakers, defibrillators, automatic external defibrillators, wearable defibrillators, catheter ablation procedures, heart failure devices. All of this was achieved in less than 5 decades. It's an extraordinary achievement in the history of medicine. And I take great pride in the fact that so many of my colleagues were there at the beginning, stayed with us through the course, and it is something that a medical student going to a school of medicine would never imagine that they could be part of a discipline of medicine. So the discipline of medicine, and I do this again in memory of Bernd, is to talk about the first reports of arrhythmia problems, the bradycardia by William Stokes, taking a pulse of a patient. It was all about pulses. And this is Konrad Wenkebach's a recording of a radial pulse showing arrhythmic behavior of the pulse. And then eventually Mobert's ladder diagram. So around the middle of the last century, interventional treatment of disease in 1947. Here are 2 examples. There were clinical dissertations. This is the famous Paul Dudley White of Wolff-Parkinson-White frame, who talked about the recent advances in the treatment of medical diseases. And a smattering of physiology. Recent observations on the dynamics of the pulmonary circulation by Andre Cournard. That's only 75 years ago. And the major interventions were beer, the first disposable syringe, and the DPT vaccine. That was medicine 75 years ago. And in the period 1930 to 1963, which is not the subject of my discussion, the first interventional treatments came, the internal and external defibrillators. But 1958 is sort of the beginning of the prelude to this talk, the first arrhythmia and the next interventions. A surgeon, in this case Walter Lillehei, was operating on children And the children frequently succumb to postoperative complete heart block. And an engineer bought a battery with a timing device with the first external pacemaker. And then subsequently the transvenous device, which I just showed. So I'm going to show you a chronology. I'm going to say a few things that you know well, some that will evoke response. And antiarrhythmic therapy from the 60s to the 2020s has sort of this pattern: antiarrhythmic drugs, antiarrhythmic devices, and ablation therapy. And if you can see for the bar graphs, you can see the fluctuations in the use of these treatments. So I divide these periods into two parts. My chronology is in the middle, the 70s to the 80s, and I will talk there. But I divide this period into two parts. Before the 21st century, which I refer to as a physiologic revolution and innovative technology. The post-21st century is what I call the age of empiricism, consolidation, and evolutionary technology. My journey actually began in the old world, and I just show this because of, again, historical interest. The creation of the city of Delhi by the Emperor Shah Jahan, and a family member proved that that we had a forefather with him when he created this. My first exposure to Europe was in 1964. And I am amazed at the things I saw. My father comes for advanced studies. He comes to the Royal College of Surgeons in Edinburgh. I learn about astronomy. They offer me a scholarship, and I have to choose between astronomy and medicine. I became homesick, and I went back to India, and then there was one choice: medicine. So I started with a few axioms in life. You know, you get inspired by great teachers who support science and support their students. At my medical school was a cardiologist, Sujoy Roy, who had returned from Harvard to set up the department there, and he introduced me to the possibility of research. Roy imbued me as a medical student with a lifelong passion, cardiovascular research. We did work on high altitude pulmonary edema, and I learned about circulatory physiology, an interest that never left me. And we published this paper posthumously after Dr. Roy died prematurely of a coronary heart disease. In 1975, I get to come to New York City, and since this is my personal journey, you'll have to bear with a few of these anecdotes. But I encounter another giant, Edward Meilman, one of the world authorities in arterial hypertension of that time. And Meilman gave me the freedom to pursue an interest. So at that time, Chatterjee and Parmley were publishing the early studies on hemodynamics and vasodilator therapy in acute myocardial infarction. And he allowed me to continue to start doing echocardiographic studies in acute myocardial infarction and infarct size. And that was my real interest at that time. And I went in search of cardiology fellowships. And you were beggars, you couldn't choose. So if you got a good fellowship the first time around, you didn't wait around for the second one. So in 1977, fate made my choice. And I got an offer at Miami. Harvard came 3 months too late, and I was in the hands of the people of Miami. But I encountered incredible individuals. Augustine Castellanos, who is not well recognized, the man who described, on electrocardiography, deciphered the mechanism of AVRT. He did not have a his-manual tracing. It was from an electrocardiogram. He thought pacemakers, which were asynchronous devices, were unphysiologic. He and Baruch Berkowitz made the first implantable demand pacemaker, the first dual-chamber pacemaker. And also over there was Robert Meyerberg. Meyerberg was one of the leading authorities, disciple of the famous Brian Hoffman on the conduction system disease and conduction system physiology. And he was working on conduction system properties that far back. He was also interested in sudden cardiac death. He was doing epidemiologic studies, and he looked at the first interventions that existed at that time: coronary artery bypass surgery, revascularization for sudden cardiac death. So my initial project, I was interested in myocardial mechanics, was regional wall motion in left bundle branch block and acute MI. It got very little traction. The PhD and the PI left, and I felt abandoned. GE got the algorithm, and I was reassigned to do antiarrhythmic drug studies. Third project did a little better. We were looking at atrial activation sequences, and we discovered that there was a slow pathway that was anatomically distinct from the fast pathway. This paper was not accepted by circulation. John Gallagher thought that the tracings were doctored, and the paper was rejected. We had to do another 15, 20 cases and prove the fact that this was anatomically. Ralph Lazara took this with him to Oklahoma, and Sonny Jackman went further with this. So 1972-78, sudden cardiac death, the first non-pharmacologic interventions are conceived. The first one was coronary revascularization, a very important fact that has been now forgotten. It was an effort to restore circulation and improve the substrate and the electrophysiologic mechanism. I'll come back to that. When I was at Marburg, one day, a movie arrived to be presented at the American Heart Association. Marburg, who was a basic scientist, was very disturbed. He saw this movie with the dog getting defibrillated, was very concerned that the animal rights people would blockade the American Heart Association, did not want this to be shown. And we had to convince him that our drugs were not working and this movie should be shown. This movie was a seminal event that could show that defibrillation could be done. And across the pond, a surgeon was changing the arrhythmia substrate in ventricular tachycardia, the first encircling endocardial ventriculotomy, Gerard Guérodon. The first ideas, revascularizing the substrate, converting the arrhythmia, excising the substrate. My journey when it commenced, 60s were electrocardiography, and 70s I talked about. Surgeons are the first champions with clinical EPs. 80s is where we start. The book at that time, Mauricio Rosenbaum's book, doesn't mention a word about pacemakers or any kind of non-pharmacologic treatment. So in 1980, I come to the first European Congress, I began my 5 years of relationships with the European leaders. I presented this paper on the sequence of dual AV nodal pathways, and John Gallagher and Hein Wellens got to chair that session. We had developed friendships over time. And I am recruited to start an arrhythmia program in New Jersey in 1980. Now, this shows you how foolish a 28-year-old person can be to come to this program. There is no equipment, no trained staff, no dedicated laboratory. But I have been given a mandate by the surgeon program that they want to do map-guided arrhythmia surgery. We start a new lab. Look at the labs of those days, the kinds of things that you don't see anymore. Mapping equipment and computerized analysis systems had to be built from scratch. And 1 year later, we did our first surgical ablation. The axiom was great collaboration overcomes all obstacles. There was great collaboration between electrophysiology, surgery, and biomedical engineers. And that's how we built our first laboratory. The 1980s, by 1980, there were limited choices in antiarrhythmic drugs, type 1A drugs and derivatives. We all got to do these kinds of studies, N-acetyl procainamide, lorcainide, who you probably never heard of. And we had response rates of 18% at 1 year and second-degree AV block. I had the emergence of amiodarone, and we had to import amiodarone from Sanofi, France, to give to our patients for compassionate use. And amiodarone is evaluated in our EP lab. So In the meanwhile, I'm with the pacemaker surgeon, so we evaluate anti-tachycardia pacing. I'm foolish enough to put anti-tachycardia pacemakers in patients without defibrillator backup, which didn't exist, but we showed some fairly good efficacy. And the properly selected patients, we could do it. Meanwhile, transvenous cardioversion had just occurred, and we published this paper which showed ATP was just as good as transvenous cardioversion. And that was the demise, really, of transvenous cardioversion. Building a full service program involved having a basic science lab. We got an AHA grant. When we excised human diseased ventricle from patients with VT, we studied it in the microelectrode lab. Drugs, and here is the first ablation studies on laser ablation and lesion size in actually human diseased ventricle. Meanwhile, the amiodarone story, we study amiodarone, and axiom 3, we challenge conventional wisdom. The New England Journal paper from Doug Zipes' group was published, and we wrote a letter saying that our observations support the conclusion that amiodarone has markedly depressant effects on all electrical activity. Now remember, it was the poster child for class 3 antiarrhythmic action. And then we showed other kinds of things. Now, we got a tart reply. We consider the comments of Saksena and all regarding the induction of VT of interest, but unsupported by their data. But the challenge is, when you're challenging conventional wisdom, persist and gather evidence. So we continued to evaluate antiarrhythmic, and we showed all the multi-channel effects of amiodarone, and said this would necessarily question its status as a pure antiarrhythmic drug. The response from Brahma Singh, who was one of the persons who made this classification, is they were surprised that they discovered considerably larger action. We all know today that amiodarone is a multi-channel blocker. But I still remained a hemodynamic man at heart. So we did these studies. We did studies on left ventricular function during sustained ventricular tachycardia. Impossible to do today. To put in a left ventricular and right ventricular catheter, have spontaneous and induced VT. And there was an extraordinary finding, never seen before in the cath lab. Changes in the pattern of behavior of myocardial relaxation and contraction of the kind. I showed these tracings to Kanu Chatterjee. He says, I've never seen anything like it. We send the paper in, it's rejected. Elliot Corday, the past president of the ACC, the world's expert on hemodynamics of arrhythmias, rejects the paper. He said, it just doesn't happen. But the greatness of the editor of JACC, Simon Dack, I appealed this paper, and I said, this is the first human study that ever done. And Dack overruled his friend and partner on this paper. And here is a tracing that no electrophysiologist paid ever any interest in, which is, here's mitral valve flow with the first 2D echo machine during ventricular tachycardia. Navin Nanda bought the first Toshiba machine to us, and look at what happens. Mitral valve flow fluctuates during VT. New regional wall motion. This is not part of the electrophysiology dictum. So, but biology never goes away. So if you don't have it, you learn to improvise. We built our mapping equipment ourselves. Look at the epoxy embedded wires, needle electrodes, and then we got it made commercially to some extent. This is 1983. We're talking about how to build electrodes. And then we got tired of measuring on photographic paper, so my engineering colleagues built the first endocardial epicardial mapping computerized system using a microcomputer, using an oscilloscope to time these tracing. And we could get intraoperative maps, epicardial and endocardial. And eventually, commercial interest develops. You get balloon maps, sock electrode maps, and you learn that if your innovation is important, commercial interest will emerge, but navigate it carefully. 1979, the next intervention is inadvertent ablation of the AV junction with a misconnected His bundle catheter in France. Scheinman decides to do dog studies to make it intentional, and Scheinman and Gallagher report the first series. And we go into the first FDA clinical with them. We get in 1985 to 1990 is the golden age of DC shock ablation and its limits. So here's a patient who was 12 years old, who had recurrent bouts of SVT with chest pain, dyspnea, double, and EP studies revealed a post-receptal, left-sided post-receptal AVRT. Drug trials failed repeatedly. In 1990, we did a DC shock ablation of a left post-receptal pathway. This is her today with her children and her ECG today. And I still have a few of these patients. But DC shock ablation had other issues. You can see here the extent of endocardial lesion of a DC shock. Catheters fractured. There was a shock wave effect. Myocardial trauma occurred. So we started to look in 1985 to 1990 at the technical advances in ablation, modifying a delivery system. This is a catheter which was a suction electrode catheter, which could be attached to the bundle of His, and a 10-joule shock could be delivered. You could get complete heart block in the animal. And this catheter became available. But then, around the same time, some other things were happening. In 1982, I saw that a report on the pathologic study on the feasibility of laser coronary angioplasty. That's the laser, an argon laser. I'm sorry, let me go back. And you can see there's the argon laser, completely occluded coronary artery in a cadaver, and laser endocardial ablation being done that opens the coronary artery, done by Simon Sursa. So I went to join them in California. The manufacturer gave us the laser, and we started our laser ablation project. At the same time, Peter came and he bought this machine in his briefcase, and he opened it it was like a Christmas present that he came. He said, and I was looking at this machine. I said, "What does it do?" And then he explained that to me, and then he gave me the first set of catheters that we could use with it, and we started the process for laser and for RF at the same time. Here's a laser fiber beam fiber, and there's a hot tip laser fiber. And on the left, this is a cadaver heart with laser ablation. This is the RF with RF lesions. There's Peter. And for Hugh Thorsten, the world's first angioscope. This was 1983. And we tried to look into the bloodstream, but not too well, but we did try. 1984 begins with our honeymoon becoming a business trip. We have a meeting. European and US doctors meet in a secluded Italian resort by the name of Maraleva. There are some extraordinary figures in this place who will later become historic leaders. Here are some of them. Axiom 8, international and interdisciplinary dialogue results in great advances. So we couldn't go anywhere. We had to stay there for a whole week. So we had to talk to each other, share ideas, think of new projects. And on the left is you can see Gerard Guéraudon and Michel Mirovsky, Roger Winkle, whose first patient had Masoud Akhtar, John Fisher. On the right, engineers. And there's Rahul Mehra talking to Peter Schwartz. These discussions were the think tank for electrophysiology. In 1983, Mirovsky starts his first clinical trial that we participate in, followed by others, by other manufacturers. And I get a standalone IDE from the FDA for intraoperative laser tachycardia ablation, and you can see that. In 1985 in Dusseldorf, there is a remarkable meeting. Basic scientists, clinical EPs, and surgeons come together to establish a powerful scientific union. Mirovsky's first device consisted of the generator, that little probe, and a magnet, and some epicardial electrode. He got approval and insurance coverage. I show a laser ablation live case, and I am immediately told that this is a barbaric procedure by one of the thought leaders, and I should abandon doing ablation. But the device that Mirovsky was espousing had its own set of problems. Here's the patch attached to the heart. 3 patches there, Medtronic tripled it by putting it 3 patches. Here's the endocardial lead completely sclerosing the subclavian vein. Not a great outcome. And then, like in any other field, there are missed opportunities. So, in 1974, the first accessory pathway potential was recorded by John Gallagher. And he labeled it AP. And John then left Duke for personal reasons, and nobody paid any attention to this observation. Rui Sung left Miami, and the slow pathway work came to a halt and moved to Lazara's lab. Doug Zives thought he would up the ante by doing low-energy cardioversion. When got Medtronic to develop this device, this mostly caused VT acceleration to VF, and the clinical was stopped pretty quickly. So we started our studies on transvenous defibrillation. I'm generally discouraged by my colleagues. We try all, they say it doesn't work. The catheter approach, ablation alone approach doesn't work. In 1984, we explored the idea of a second shock vector, and we started putting patch electrodes to try and simulate a second pathway, and that started working. And then eventually with the implantable device, we checked the catheter patch system, and it worked. This is the first human implant with a left-sided subcutaneous electrode, and you can see the defib, the threshold was 10 joules with the monophasic shock. This is the patient spontaneously having an event and was resuscitated. And now we had a non-surgical approach for defibrillation. But there is a vicious backlash, partly because pharmacology was the standard of care, and we were doing all these studies, which were poorly understood. And our clinical studies on laser ablation, ADP, transvenous defib are challenged as unethical, unsafe, and even the veracity is challenged. And there's local, international, national media backlash, and the concern grows. And that's how the first live cases were done. My response to that was to do live cases. So we did live closed heart laser ablation to show them it was not due to mechanical surgery. We did defibrillation cases on live status, and these are the first defib cases. And then we had this tragic case of a physician who came to seek a transvenous lead system. He didn't want a thoracotomy, sternotomy. He was number 6 in our series. He was having Christmas celebrations with his family. He felt a little electrical current in his shoulder. It was Christmas Day. He decided not to bother us. The day after Christmas, he was found dead in bed. And of course, he had that lead fracture. We could not get this paper published with great difficulty. The first ICD lead failure was published in the Archives of Internal Medicine because of the difficulty. So then we started doing what was the real test. VT ablation in a warm beating heart. So here's the patient. There's the first patient on the left, which was done with open heart. But this is a warm beating heart, not cardioplegia, in the patient number 5, and you see VT stops. The same patient in 2019, after the VT ablation in 1987. Later in life, he required a device for rage support and heart failure, but this is roughly 32 years later. So we published these series, and we had to show that ablation really worked, that sudden death was not an issue. Epicardial laser, closed heart epicardial laser ablation to show that you could ablate WPW with 2 laser pulses. Here's the RF ablation with Peter's device, and this became a real reality. So in 1987, Hein Wellens decides that he really has to pay attention to this non-pharmacologic data set. And he has this meeting called Where to Go From Here. And it's mostly pharmacology, but it also allows us to appear on the screen. And here's laser ablation on the program. And this is the first time that ablation appears as a real thing. How do you make a scientific field? So you have to put together the knowledge, and these are the first books where we talked about pacing, anti-tachycardia devices, catheter ablation. And suddenly, it was no longer some esoteric thing. There was a body of knowledge. And then came my great collaboration with the group of German cardiology led by Bernd and Gerd Steinbeck and many others. And we coined the term interventional electrophysiology. So how do you define a new field? Worth of an idea to the first scientific meeting. Bernd wanted to call this management of cardiac arrhythmias. He acceded to the idea of calling it interventional electrophysiology. And that is his poster right there. The first poster of the first meeting at Königswinter on the Rhine. We felt that every 4 years there'd be more knowledge, so we crossed the water, Newport, Rhode Island, and repeated this for the next 20 years. And that is how our collaboration developed. And the next part of this, the next 20 years, interventional EP is discussed and published worldwide. Branding. I'm using your term. You must have branding, right? So how do you brand the term? You have books and a dedicated journal, and that's what came. Essentially, what today they would, and the editors continuously debate what is the definition of interventional, what is the appropriate scientific content. But other things are happening. Now we come to the turbulence in our field. New drugs are discovered, 1C drugs, which show much greater ability to suppress PVCs. Enconide, flecainide, 83, 80, 79%. Intolerance is 3 to 5%. Proarrhythmia is 1 to 3%, at least in the early study. So the NIH embarked on a post-MI trial. And there, the trial was abruptly terminated. There was increased mortality in the active treatment arm. That was responsible for trigger suppression. And the important point I leave with you is the trigger suppression hypothesis in the ventricle becomes a failed hypothesis. Trigger suppression became a failed hypothesis in the ventricle. And then the alternatives were looked at. So we decided to have a policy conference, the first NASP policy conference on the implantable defibrillator. I was one of the chairs. We had a great faculty. And I decided that this has to be brought to the attention of the NIH. So I invite Salim Yusuf, a preventive cardiology specialist, to come and to this meeting. Salim is not keen to come to this meeting. And at the meeting, he attacks the data that was presented for the effectiveness of the defibrillator as being scientifically untenable. It's observational. There's no randomized trial. It took me 3 months to get wording on the statement worked out, like negotiating a UN statement with Yusuf. But there's unexpected events that overtake you. Then you persist. So I told Salim, I said, if you really think that devices are a problem, put your money where your mouth is. So the NIH decides to enter the process, and the first clash of titans commences, NIH versus industry. And industry does not want a clinical trial. They have the approved device. And Yusuf and I met in New York City. He agrees to fund an $8 million trial. I'm too junior to lead it, according to Dr. Brownwald, and the trial planning begins. And editorials start appearing. Why the antiarrhythmics versus implantable defibrillator trial sets the wrong precedent by a current past president of Heart Rhythm Society. Other people, there should never be another AVID trial. We, meanwhile, are planning this trial. I request an ejection fraction strata analysis based on our work and Akhtar's observation. The observations were that Akhtar was impressed that people with depressed LV function lived longer, more than expected with the ICD. We saw that they were using the shocks more often in moderate to severe impairment. So request analysis. The trial starts. It's prematurely terminated for efficacy, but the AVID coordinating center refuses to do an ejection fraction strata analysis as they forgot to include it in the statistical methods. That's the trial. It was interrupted. Important lesson, do not do trials with immature technology or the wrong population. This was the sustained VT population we have. Highly effective. Finally, we persuaded the statistical group to do this analysis, and to the surprise of everyone, it was not the people with well-preserved ejection fraction who benefited any more than amiodarone. It was the low EF group. And this setup, this was, so the message being there are pearls to be found even when the results seem unequivocal. Everybody was convinced the device works for healthier patients. We had to learn about technology developments, how to deal with businesses, patents, all of that stuff. That was part of the issue for our foundation. But despite turbulence, we continue working with new leads, shock patterns, biphasic things, and we have good results. Now, at the same time, ablation was now focusing on the physiology. Lazara took it to his lab. They pinpointed the location and they did RF there, and the rest is history, as you well know, that here's selective AV nodal pathway ablation that came from this work. Successful interventions came from the understanding of anatomic physiologic relationships. Here's Martin Vograf, another year of first, doing the first WPW ablation. And here is the Jackman series. There's the RF I showed you before. So designing, when you do successful interventions, when you understand, the results are durable. 25 years later, this young lady had an RF pathway ablation, and she got to be a ballerina in her time. 25 years later, the technique has remained pretty much the same. Now we enter our next period, which is the late 90s. Pulmonary vein triggers are identified. There are the figures you've seen. They map triggers in the pulmonary vein, not much in the right and left atrium. And this is an online analysis at that time. The trigger hypothesis reemerges in the atrium. It comes back. It died in the ventricle, but it came back in the atrium. Has a resurgence, but there are some warning lights. The first paper, when the Bordeaux group, the first paper that questioned it was the group from Hopkins that said a single procedure had efficacy rates of 30 to 40%, even under 30% for persistent AF. The Bordeaux group reanalyzed did a new study, and in that study they showed, yeah, about 60% have a recurrence about in 1 year. So they advocated multiple procedures, and PV isolation becomes the standard. But I'm a clinical cardiologist, and I made rounds one morning, and I saw a patient of ours. At 9 o'clock, there's the initiation of atrial fibrillation right here. PAC initiates atrial. At 10:30, it stops. Now, I don't see any PAC there, but it stopped. And I'm trying to figure out why it stopped. At 2 o'clock in the afternoon, there's frank atrial fibrillation. At 3:05, there's type 1 flutter. At 7:43 in the evening, there's a different flutter. And the question came, can mapping explain the many manifestations of AFib? So we decided to do biatrial mapping. We did simultaneous biatrial mapping. And here's one of the early electrogram maps. And clear enough, sure, here's the pulmonary vein trigger going on. But then things start changing over time. And then we see it stop. And mapping explains how AF terminates, because there's only one wavefront left at the last minute. But it's only one beat when only one wavefront is left. There are just a few beats earlier, there are two wavefronts. But nobody cares. This is observation of no clinical importance. And I say atrial fibrillation is an organized rhythm, and the audience response is not too good. So this work went away. But we come to the 21st century, and I say to you, biology is an unforgiving mistress in the age of empiricism. But there's still hope. So we start here, and now things are empiric. We are back to trigger ablation. And we now have evolutionary technology, consolidation of mapping technology, new catheters. But see, we keep getting in conflicting data, and interpretation is a major impediment in progress. Same piece of data is presented two different ways by two experts. And then there are macroeconomic changes in healthcare and conflicts of interest. Arnold Relman, who used to be the editor-in-chief of the New England Journal in 1980, wrote an editorial called The Medical Industrial Complex. He famously noted the most important healthcare development of the day is a recent, relatively unheralded rise of a huge new industry that supplies healthcare services for profit. And close attention is needed to monitor this. But the age of empiricism and evolutionary tech continue, but they discover, once again, biology is an unforgiving mistress. Now we have very nice maps, we have a bunch of devices, and we do more and more procedures, robots, imaging, left atrial appendage occlusions. But we still have controversy. We design clinical trials extrapolating epidemiologic data very simplistically. So my old boss, Bob Meyerberg, pointed out high-risk subgroups. But he never said that you take the entire LV dysfunction population and do a clinical trial. So we do a trial. We do clinical trials. They're redesigned with a blunderbuss approach. Just take everybody in, do the intervention, and sure enough, they came out positive. Here the ICD was better than placebo and amiodarone. So the result was we get implants in all LV dysfunction patients. And then we find out that 4 out of 5 ICD recipients do not use their device. There are prophylactic ICDs. What will happen in the medical market? We now have a problem. We have a trial, our gold standard, and we have patients not using the therapy. So a PhD in finance sent me this graph, and I put a title on it. Innovation based on knowledge is revolutionary. Empiricism is rarely durable and eventually replaced. So here's a major manufacturer starting their journey. And the invention, the artificial heartbeat. They invented the artificial heartbeat. Revolutionary technology to capture that artificial heartbeat and deliver it to a patient. Look at the exponential growth in the market cap of this company. Over the next period, between 1985 and here we are at 2000. After that, we enter a plateau phase. It starts growing again, but it's now the non-cardiac business, merger and acquisitions, movement of financial resources that drive the growth. So my comment when I got this was that the most enduring and significant contribution in the history of medicine will be that of the individual who saved the critically ill children by an equally gifted man who gave them the first artificial heartbeat. So we start rethinking the blunderbuss approach. Now we have sudden cardiac death stratification. Remember Bob Meyerberg who wanted to revascularize patients? We suddenly start thinking about the substrate. And we think about device implantation growth in emerging economies. And I keep repeating my refrain, biology is an unforgiving mistress. And here is CRT data, 30–40% non-responder rates. We try to come up with X-rays and measurements and all of that. And here is a very simple experiment. under direct vision. You see what you're doing, your location. A surgeon puts 4 electrodes 2 centimeters apart. And we have a monitoring mechanism, an intracardiac echo catheter. The ejection fraction varies from 39% to 61% located on the electrode. Here's a physiology lesson. And you know what it required? It required somebody to see what they were doing and somebody to measure the hemodynamic response. So I always ask this question. I'm not popular with my EP colleagues. In cardiology, we do interventions with guidance. On the left is a coronary angioplasty. How many of you would accept doing a stent with no post-stent imaging? But in EP, there's no imaging after a device implant. And I asked that, and this is ICE-guided CRT implants, and you can see we don't have 40% failure rates. So I say this with age and my thoughts in this, that we need to stop working in silos. We need to have interdisciplinary research. And I'm glad to see that is happening. So now we are looking at more physiologic mechanical resynchronization. Here's CRT and activation patterns. And we now turn to old physiology. His bundle pacing that was done in my time in Miami, a long time ago in the 70s, but it is physiologic activation. And now we are targeting the His bundle to get more physiologic activation. They still don't know a whole lot about the physiology of the bundles, but at least we are getting there. And we are doing imaging to prove that it is more activation. And we are able to see. We are able to now move this ball forward. Another serendipity observation. A surgeon who kept on talking about his appendectomies in his cardiac surgical patients, reducing post-operative stroke. He did 437 visits, Dudley Johnson. And eventually, someone listened to him, and my friend Michael Lesh left academia. He rented lab space in Mountain View, California, and designed the first left atrial appendage device. And of course, the rest you all know. But now we still have a problem. The NIH invests and designs a mortality trial for 2 AF treatment strategies in 1996. I was on the planning committee. I was in charge of the non-pharmacologic piece of it. We get the results in 2002. Arrhythmologists are staggered by the inexplicable outcomes. The rate and rhythm arm did pretty much the same. Though if you looked a little bit better at it, there were only 37% more patients in sinus rhythm in the rhythm arm than in the rate arm. And that was the premise: more sinus rhythm, better outcomes in mortality. Nobody asked the question, we didn't, I was there as well, how do patients with atrial fibrillation die? What the trial shows was if you didn't give anticoagulation, you did die. You died of stroke. But how do patients with atrial fibrillation die? So clinical trials summarize behavior of disease. That's the first phrase. With respect to measured endpoints that are clinically relevant, your endpoints have to be clinically relevant to the period of the trial and over the period of time of the trial. So when we look at that, we'll come back to that. But we ignore the warning lights. We decide that drugs are not very good at maintaining sinus rhythm, and short-term clinical trials with arrhythmia endpoints take place series after series. We put out guidelines supporting catheter ablation as the method for rhythm control. And none of these, we ignore the cardinal rhythm rules of clinical trials, clinically relevant endpoints. And we have hasty guidelines. In 2005, Philippe Coumel made an admonition on his retirement lecture. He said, after Claude Bernard's inauguration of a method that presupposes understanding before treating, that places diagnostic approach before therapeutic sanction, isn't modern cardiology in the process of moving to the opposite approach, which consists of treating before understanding? So the AFFIRM trial is a lesson in exactly this. So we have more warning lights. Short-term results, efficacy levels of PVI, are limited, even in 1 year. AF is a lifelong disease. We move 10 years forward. We now have radiofrequency, cryoablation, and pulse field ablation. There's no difference in outcomes. And we readjust expectations. We say it doesn't cause AE fistulas, we like that, but we ignore warning lights. The troponin rise in these patients is in the hundreds, much more than RF ablation. If you have an MI with troponins in the hundreds, you get very concerned about that patient. And then this is 2 weeks ago, and 2 years ago at ESC. Pulse field ablation and thermal ablation, identical results. A sham procedure, a sham PVI procedure, and a RF PVI procedure. PVI reduced the AF burden by 25%. Remember AFFIRM? 37%? This is a very serious question now. So what is the natural variability of the disease? Do we understand the disease? And this is more of Relman's concern about conflicts of interest in our healthcare environment. And he published an editorial on that. So we continued our work, not much attention to it, but we showed this at the American Heart. Here are triggers, all coming from the septal area, right pulmonary vein area. And the startup tachycardia is in eight different locations in the right and left atrium. It's all about the substrate. Here's cascading. Now, we did it with so many techniques that one tachycardia follows another. There's more and more evidence of multiple regional substrates. You know, the atrium and the ventricle can't be different. The triggered hypothesis ended in the ventricle. It has to be the same in the atrium. And again, we look at paroxysmal AF, how it stops. Nobody cares, but it's still that single wavefront. Now, why is this important? Because if it doesn't stop, your AF burden is much more. And what does AF burden do? But nobody cares. Instead, they start looking at electrogram phenomena, which are end collisions between wavefronts in two parts of the heart, and they start ablating all over the place. These have nothing to do with the price of tea. But we finally recognize non-PV triggers. They get into the guidelines. But, as I repeat again, biology is an unforgiving mistress. So what you need to know is what happens in vivo, not what happens for 2.5 hours in an EP lab in a general anesthetized patient or partially sick. What happens in the walking patient? So these are implanted pacemakers with a natural history follow-up. And the pacemakers measure the triggers, the PACs. The blue measurement is in patients with no cardiovascular history, 69 of them. 260 had a cardiovascular history. Look at what happened. The ones with no cardiovascular history had thousands of triggers every day. The ones who had cardiovascular disease history had much less. And then over time, these remained a little lower. These got lower, but there was a marked difference in behavior. What happened to atrial fibrillation burden? It was the reverse. AF burden slowly went up in the cardiovascular disease patients. It kind of just stuck around the same in those who had no heart disease. Then the question comes, this is what's happening in vivo. What happens the day they get their first episode of persistent AF? The day they get their persistent AF, the week before, they have very few premature beats. They get 1 or 2 of them, and there we have 100% AF burden. Now, does 100% AF burden always remain? Answer is no. They have 7 days or more of AFib, and then it can stop. And therefore, the substrate that maintains multiple triggers is the substrate. Now, here is Johannes' study, the first real study with a clinically relevant endpoint, heart failure endpoints. He measured heart failure endpoints, showed the benefit of catheter ablation. But he got a lot of blowback. He got a lot of pushback. Marouche was very unhappy when he debated Milton Packer. Lots of details of clinical trial. But the question I asked, why are our heart failure colleagues so skeptical? Is it only due to trial design issues? Much more likely is they do not believe rhythm control benefits the course of heart failure. And why do they believe that? If so, why is that the case? Maybe it's due to the fact that there is no proven independent physiologic mechanism by which rhythm control is proven to impact heart failure. We do not know the physiology. And AF burden is important not because it logs up your programmer, it's important because it has something to do with this physiology. So we went back to the AFFIRM trial and we looked at the patients who had no heart failure, normal EF, whatever at the start, and I'll kind of cut this short. We matched these patients in rate and rhythm, and what did we find? The reverse. That if you had a certain level of rhythm control, you didn't develop heart failure. Whereas if you didn't have rhythm control, you developed heart failure. Rhythm control prevented emergence of heart failure. Heart failure is the most common complication of AFib, and rhythm control is important to delay it. And does that matter? Well, it did in AFFIRM. 1 heart failure class, 2 heart failure class. Look at the mortality risk, 2 to 4 on relative risk. This is the middle step that was missing. And AFFIRM never looked at heart failure endpoints. Johannes did. And the middle step occurs over a period of time. How much time? Mortality comes later. So here is AFFIRM reanalyzed for heart. Look at the heart failure emergence curve. They're actually the reverse of the original main curves. And rhythm control is positive. So then, how does this tie in? Well, we've now got new epidemiologic studies. Heart failure is the most common complication of AFib, AF patients. We've got epidemiology, the Danish study, here's the Dutch study. These are new truths, heart failure, XV, stroke, and vascular events. And this ties in with that combination. So I'll move along a little bit because of time here. This is the next study we did on the TopCat trial, where AF, like all the time, was a marker of poor outcomes. But why? So we matched the whole group of patients in the 2 arms, those who had paroxysmal NEAF and those who had persistent AF. And what did we find? We see the cardiovascular death goes up, no question about it. But what happened next was startling. AF had no impact on sudden death, both NEAF and AF on EC. But it increased pump failure death remarkably. AF produced mechanical failure faster. And how did it do that? What's the step in between? It increased progression of heart failure class, which occurred here. And if you had class 3 or 4 heart failure, then you had pump failure death. So the answer being that when you get AF, you start thinking of what it's doing to heart failure. Finally, the last piece here, here's a trial done on the basis of fibrosis seen in the atrium, MRI-based trial, negative. Why? We see the scar. Well, we don't know the physiology. We now have an atrial cardiomyopathy that we define in classes. But the real thing that's happening is there's changes in molecular biology. There's changes in microRNA. There's apoptosis, cardiomyocyte hypertrophy, smooth cell proliferation, apoptosis, blood vessel growth, and fibrosis and inflammation. And it's not all irreversible. It changes. Fibrosis, which we consider permanent, is not. It's a dynamic phenomenon which do many other things. So let me try and hemodynamics matter in producing a big popularity. So, and now we see what my last speaker talked about, affecting the basic mechanism in the substrate. So he's talked about all this. I'm not going to talk about this. I'll mention this pacemaker system that is not used anymore for AFib, but we have had startling good results when we add it onto ablation or drugs. And why is that? Because we improve mitral valve filling. And what does that do? It changes the substrate. Look at this atrium, 12 years later, 5.2 centimeters here and 4.1 here. But it doesn't work alone. The pacemaker companies did a whole bunch of trials trying to use the algorithm. All failed. Because it's an add-on therapy, just like CRT. CRT doesn't work without heart failure drugs. So what is the mechanism? You have to change the substrate. And here's a lot of data that supports that. Again, atrial resynchronization, something for the future. And all kinds of data that supports that. And there is no trial at the present time for looking at this. We have done this in our sites. But the last piece I'm going to leave you is here. Many years ago, we proposed that you should do hybrid therapy, combining drugs, pacing, ablation, and showed long-term results out at 5 years. So here is something today. 87 million patients in the Optum database. 2.4 million had atrial fibrillation in a 14-year period. 2.4 million. 23,000 went on to ablation. And 12 months pre-diagnosis, index event, and then we looked at re-ablation. The largest catheter ablation study ever presented. Look at what happened. 1 out of 6 got a repeat ablation. That's right here. Some had, 83% never got another ablation. They got antiarrhythmic drugs, amiodarone being the most frequent. But over 60% got antiarrhythmic drugs. 2 ablation, same pattern. Actually, they got more, 62 here. 3 ablations, 69, 60. So I rest my case that today, until we have molecular markers for treatment, we have to combine treatments. So let me conclude again and say, let me leave this aside. We talked about conflicts of interest, and these will be the future, and I won't talk about these. These are all molecular markers that will be diseases of aging and all of that. So I want to sum up by saying science is built up of facts as a house is built of stones, but an accumulation of facts is no more than a science than a heap of stones is a house. So there must be a reason. I'd like to thank all my collaborators over 4 decades, and more importantly, the unflinching support of the trustees of my foundation. And importantly, our legacy continues, Bernd and I. I'm truly grateful for to the organizers of this meeting who continue this work and will continue to share new truths with you in years to come. Thank you very much for your attention.
Thank you, Professor Saksena, dear friend Sanjeev, for a wonderful and thorough ride through 5 decades of electrophysiology. This was really wonderful.